Hello, my name is Jill Berry Bowen, CEO of Northwestern Medical Center, and your host of the NMC Health Beat Show, dedicated to discussing important healthcare topics of interest to our community. Today, I'm joined by Amanda Wilson. She's a medical social worker and part of our inpatient care management team, and also Kristen Tuttle, who is the nurse care manager for Oncology and Palliative Care at NMC. So today we're going to be talking about a pilot for palliative care in our community. So thank you both for joining today.
Thanks for having us.
I think this is going to be great information for our community, and so we're going to jump into the topic, but first and foremost, I think we should let the community know who each of you are. So maybe tell us a little bit about yourself, how long you've been at the hospital, and what your work is.
Sure, so my name's Amanda. I've been with NMC for just over a year now. Before that, I worked in the community for a home care agency for about 4 years and a long-term care facility for over 4 years. So I've been doing the work in Franklin County for about 10 years now.
That's terrific, thank you.
I'm Kristen Tuttle. I'm an oncology nurse and an RN care manager at the hospital. I really work with the cancer patients and the cancer patients in the community, not specific to any provider, just making things easier, trying to work the system. I've been an oncology nurse for a little bit over 20 years. I've worked lots of different places all across the country, big places, little places, so lots of different experience. And I have this cool job where I just get to help people now, and I don't have to do a lot of the other, parts of it. It's just what can I do to help, which is amazing.
Oh, that's fantastic. And in an area that people really need help navigating the system and their disease, so that's pretty cool. Well, let's start off by actually defining what is palliative care.
So the way that we decided to define palliative care and sort of the universal definition of palliative care is just a care system that's meant to provide symptom management and improve quality of life in people that have a life-limiting or a life-threatening illness. So it's just a little bit different way of looking at care. It doesn't always focus on curing a symptom. Sometimes it's really just focused on trying to decrease that symptom's impact on a person or the person and the family that is having that symptom. So it's kind of a different way of looking at things, not as much aggressive treatment, a lot of just really focused symptom management and education, support. It's just meant to be supportive for patients and families.
Okay, so when I think about that definition and I think about hospice or end-of-life care, I think it would be helpful for our viewers to understand what is the difference between palliative care and hospice or end-of-life.
Yeah, it's one of the big things that we're focusing on when we're providing education to community members, to providers, to staff, basically to everyone. We're really trying to make clear the difference between hospice and palliative care. And there are some pretty clear differences. Hospice is a Medicare or a Medicaid or an insurance benefit. It's meant to be used by people with a terminal diagnosis and people that have a life expectancy of around 6 months, so towards the end of people's lives. Palliative care is meant for people with a life-threatening or a life-limiting illness, so a chronic disease often, but that are sometimes earlier in their course of their disease. So focusing on providing support and comfort and quality of life. Both programs are focus on that somewhat, but what we try to do is say that we can empower people to make decisions, look at their lives a different way, support them with palliative care. People on palliative care can still receive sort of life-sustaining aggressive treatment if that was part of their plan and what they were interested in. So palliative care looks at supporting people through life-limiting illness anytime during that sort of span of their disease, not just in the final maybe 6 months or towards the end of their life.
Great, thank you.
Yeah.
So maybe talk a little bit about the pilot. I think you've got a pilot that's happening, and maybe we could talk about the pilot, and then, how does what's the plan to improve the quality of life in the pilot?
So about a year ago, Kristen and I started talking about palliative care and looking at our community, all of the organizations, how people were receiving their care for these chronic illnesses. And we developed an assessment, and we put that out to healthcare providers to really find out what were we missing, what did people know, how comfortable did they feel talking about palliative care, and that helped inform our goal. So we're really trying to develop a program that can test out providing a different type of palliative care. So a lot of palliative care models, we did a bunch of research, are very physician focused in big hospitals. We're not a big hospital, we're a very small family community, which is our strength. So we want to build on our strength, which is having the patient and the family at the center of the care, and we're building a model around that so that their team is already around them and they're really driving the care. So the initial pilot is, our goal is to launch it in January of 2018. The first thing that we're really doing is focusing on education, as Kristen started talking about, to make sure that all of our community is really sure of the language that they're using, that we're providing the same care with the same language, with the same meaning, no matter where people are. And if we can initially increase that knowledge base and make people comfortable, then we can inherently improve palliative care just by doing that. So we really need to start there.
So how do the patients get connected? So you've got the education happening, and so how do they get connected with palliative care? How do they know they even are eligible or should ask for it? So how do we make the connection?
So when we did an assessment of the community and looked at where we could start to do sort of a small pilot that's a measurable thing that we can dial in and make sure that we start small, we can get it right before we make it big, we really determined that COPD, so chronic obstructive pulmonary disease, and CHF, congestive heart failure, were two diseases that had groups of patients that were in this really vulnerable place. These were patients that had often multiple ER visits or multiple hospital stays, and that what we were doing in those ER visits and hospital stays weren't things that were necessarily changing the course of their disease or their outcomes. We were bringing folks in to get them back on top of something and then sending them home to sort of do the same thing. And so when we looked at that, we found a place that we could hopefully make a difference. That if we could identify these patients based on, and to start, they'd be identified in either the ER or inpatient when they're there for one of the stays. And then open up a conversation about whether the patient's interested in having a different way of managing their disease, a different set of people involved to try to support them and keep them at home. It's a lot of anticipating symptoms ahead of time. So knowing what a typical disease process is for CHF, being able to anticipate what some of those difficult to manage and frustrating symptoms are for patients, and then being able to give them tools and support to stay on top of it. So instead of waiting till you're really sick to have to go to the ER, when your weight starts to increase by 3 pounds a day, being able to look at your paper and say, this is what I do when my weight goes up, and then I call this person. So having a plan that the patient knows, that their care team knows, and phone numbers and people and support to be able to stay in the community and not have to go into the hospital maybe, or to decrease the amount of time that you have to be in the hospital if you do have to go in to get back on top of something. So that's sort of the structure of the program. It's really an enhanced discharge planning, enhanced increased assessment, anticipation, working really closely with our community partners, our facilities and our home health agencies that are in the community, to be able to smooth these transitions to home and then support people when they're there.
I think one of the great things that care management does is we have a bit of a different lens with the nurse social work partnership. when we're doing assessments for care, we're really looking at some social determinants of health. And there's a lot of research done around CHF and COPD and how environmental factors really influence our health. And we're able to take that lens into our assessment process and really talk about things like air quality in your home. Growing up on a farm, what does your work environment look like that you're returning to? Do you have, clean air conditioners? Is it pilled carpet at home? Access to dust. There's been a lot of research in Seattle around clean air housing and how they're building the community, which also is aligned with some of the movement that's happening in our community now. So about having access and just this change in a healthy environment in our entire community. So I think the palliative care movement, this pilot is really aligned with a lot of those other things to really look at just not the person as having a disease, but the person within the environment and how that's really influencing their healthcare, their choices, their challenges. And that's what care management really gets to do.
So it sounds like it's beyond the two of you. So who else is on this care team that is circling around the patient? I have this visual of that. We were just wrapping around these patients. So who else is part of your care team?
So for the pilot within the hospital, when folks are identified, their entire care team in the hospital setting as usual, plus we're partnering with the primary care offices, with the nurse case managers and the doctors there, so that we have a planful continuum of care. The planning process for palliative care is great. It started with Kristen and I, and now it's expanded to have home care agencies involved in the planning and the partnering, local skilled facilities, so long-term care facilities. NCSS is coming to the table. Multidisciplinary groups from within the hospital have started work groups and are really working towards making sure that the pilot works. What we'd really like to do, and I think what's missing, is having the person's voice. So we're open to having, we're asking for someone or some folks from the community who are living palliative care to be part of this planning, because I think that's really important, to give the voice to the person with the experience too.
The voice of the patient.
Yeah.
It's powerful.
Yeah, it is.
So when you do this pilot, how will you know if it's successful? What are you hoping for? And what are you hoping for our community?
Yeah. I think our long-term goal is to be providing this sort of elevated level of service, this enhanced level of everything for all of our patients, everybody that's interested in palliative care. I think the key part of a pilot program is that you start small, identify an area where you want to make a difference and a population of patients that you can manage to start off with. The key being that then as we work this pilot program, we're sort of tweaking things and making changes and making sure we're doing a really good job before we start to add diagnoses and make it bigger. We want to make sure we set really stable, broad groundwork and build a tower that's going to be steady and stable and provide support for these patients. We don't want to build a really quick, tall, skinny tower that would potentially fall over if we put lots of people in it. So slowly, thoughtfully working this process, starting off small. We want to make sure at some point that we were doing all the right things for all the patients all of the time, but starting off doing lots of great things for lots of people as often as we can. So making a difference where we can, knowing that in the long run we'd love to have this program available for everyone.
And I think we also have some measurable data, which is nice, and I'm a fan of. So the needs assessment that we started out with, we asked questions, do you know the difference between hospice and palliative care? Do you feel comfortable talking with your patients about it? And because we've assessed that early on, now we can provide education, a program, and then reassess that same data. We put that out to the entire healthcare community in Franklin County, and the results were about 76% of respondents knew the difference between hospice and palliative care. It's a little over 3/4. 70% felt comfortable talking with their patients. We want that to be 100%. And there's no reason why it can't be. And doing that alone, just the education, is going to help improve the quality of care for our community members. And we can measure that, we can show that.
That's fantastic. Our time has flown, and this has been just an amazing conversation. And thank you for taking on this great work. for palliative care, not only defining it, but impacting the lives of our community. This is so impressive, and talk about quality of life. And that's really what you're trying to do, is that they may be moving close, following through on their disease, but you want to maximize or optimize their health as they experience this chronic disease. So
It's a great way to say it.
yeah, it's beautiful. Thank you so much for being here today.
Thank you.
And I'm Jill Berry Bowen, CEO of Northwestern Medical Center, your host today for Health Beat. And what an amazing conversation to talk about how we enhance the quality of life. No matter where you're at in your life's journey, we want it to be the best experience. So we're here for you, and I'm so proud of this team for taking on this kind of collective community approach and wrapping around you for optimal health. Thank you for joining us today.